Welcome back to the Connected podcast. In this special series, we step into the world of healthcare leadership through the voices of advanced practitioners working on the front line. From community clinics to acute care, these conversations explore what leadership looks like in real practice, messy, meaningful, and always evolving. In this episode, we speak with Viqui Savage, an advanced mental health practitioner working within community adult mental health. Viqui shares her experience of leading within multidisciplinary teams, offering valuable insights into what makes teams function effectively in complex healthcare settings. Welcome back, and I'm really thrilled to introduce today, we have a lovely guest, Viqui, who is joining us to talk about her experiences with leading within a team. So before we go any further, Viqui, do you just want to introduce yourself to our listeners and tell us a little bit about your current role?
Hi, I'm Viqui. I'm an advanced mental health nurse practitioner and non-medical prescriber and clinical lead in a community mental health team for working age adults in North Norfolk.
Fantastic. What kind of led you then into a leadership role? Because we all start, don't we, feeling really fresh coming out of, qualifying and stepping into the wider work place, and that can feel daunting enough. And you've kind of obviously gained lots of experience and you've gone along this journey, and then you've stepped up even more into this kind of advanced leadership role. So what kind of led you to that?
Oh gosh. Well, I've been working in mental health. I qualified as an RMN with a diploma back in 2001, before degree became mandatory. I worked in different. I started as a little baby D grade before Agenda for Change on the wards. I started in a secure unit stroke PQ stroke forensic ward, then moved to acute wards, and after that in about 2005 I finished my degree and went to work in the community. I did have a short post as a night charge nurse on a ward as well, and then went across to the community, and I've been there basically ever since. Started because I was a charge nurse on the wards. I went across to the community as what was then a G grade, so that would be what is now a band 6 senior community mental health nurse. I stayed there as a care coordinator and lead care professional, with my main interest in supporting service users with complex emotional needs, also known as personality disorder, lots of whom have experienced childhood trauma. So that's my main area of interest, and my passion is to move further towards non-pathologization of mental distress and trauma-informed practice. As part of that, the progression into advanced leadership has been about wanting to see change in a kind of nation or a society was a better word, where people are wanting more pathologization, more treatment, more being able to take a pill and not really having to do much. Walking away from that and trying to get people to acknowledge that actually a lot of mental distress is a normal reaction to abnormal events, and we need to be working with that to see lasting change rather than a sticking plaster. It's one of the reasons why, as well as us having genuinely less doctors and a more tight resource pool, one of the reasons I did my prescribing prior to starting on the pathway, and one of the reasons I did that was to prescribe less, to be able to deprescribe medication and to look at alternatives alongside medication, rather than just having nursing seen as the medical model, and that was kind of it. Then when I I then, after I got the prescribing course, after I passed that, I kind of got the bug again to go back into education. And I felt that the NMP really means that you need more backup, more research, more time, more to be able to use that valuably and to have more of a voice. Having the four pillars of advanced practice and having that acknowledged was the way to go to be able to make more change.
Wow, it's going to be incredible to talk to you because you've kind of got this wealth of experience from all these different places, from community to acute and who knows where in between.
Mm.
Because we know that these roles take us, into new environments and with different people all the time. So I'm just thinking with all the kind of service users and colleagues and the systems that you've worked within previously, what kind of do you feel makes a team work well?
The first thing is trust, reliability, and psychological safety. Having the security in a team to know that everybody supports each other, that everybody has got each other's back. It's okay to make mistakes because it means you're open to learning, to be able to say that didn't go well and be supported in that and be able to move forward rather than feeling like you're going to be blamed. Um, I will always offer to go to people with people if they have to go to coroner's court. Unfortunately, in our field, if you like, we do see a lot of self-harm and people ending their lives. And that can be a very, very difficult experience for everybody. But as we're focusing on staff here, for the staff group who've been involved, it's really, really difficult, especially with media scrutiny and everything that's going on at the moment. So backing people up, making sure that everybody feels part of a team and that every controversial decision, every positive risk that we take with somebody is made as part of a team decision, so no one person is singled out. As part of that, I also do caseload supervision with everybody on a sort of 12-week-ish basis. So we go through everybody on the caseload, do a really deep dive just to make sure that everybody is going in the right direction, that there's plans, there's exit plans, there's really, really, really important to have crisis plans. So if anybody phones up in crisis or if anyone has a problem, the person answering the phone has that plan and says, oh, this is because when people go into crisis, often they've lost any kind of sense of how they can manage it. And just going back through that plan can be really empowering and just bring them back online, just kind of reduce the static in their poor little limbic systems and bring them back to realizing actually I can take control of this. And unfortunately, it's very instinctive for us to rescue people when they're in crisis, and it's really important not to do that. And that's where things can get quite tricky for a lot of people. And actually, we as a team, it needs to be safe enough to say, no, this is what we need to do to support this person and get them back online. If we jumped every time someone said help, then we would just be creating more dependency and less mastery over situations. And that's not what mental health service is about these days. It's about recovery and self-management, just like other long-term conditions.
Yeah, and it's really fascinating because there's so much within that, in terms of the team feeling safe and, as you
Mm,
say, having a team approach. So it's very
mm,
holistic, in the
mm,
same way that you would be planning, your service user care,
mm.
and ensuring that everybody can respond to those service users because
Yeah.
you don't know at what point. somebody's going to call and hit that crisis point. And obviously it'll be different in all sorts of teams, but having those transferable skills around kind of working collectively as a team, having organized systems, supervision, that psychological safety to ensure that the team feels that sense of kind of I guess protection as well as belonging will help all teams kind of thrive.
Yeah, it comes up time and time and time again in inquiries like that actually that kind of way of being had been suppressed because people thought they were going to be blamed if something went wrong. And unfortunately, that is something over the last, not so much now, things are improving, but over the last few years, over the last decade or so, we've very much been confronted with that, with things like the local press and whatnot in the trust. So there has been a lot of kind of like almost like an institutional trauma when people started being named in the EDP and people, things like that really affected people. Staff have been known to get death threats from members of the public. Lots of, really difficult stuff to deal with that's affected people's lives. And it has felt that has been a culture of blame. That one person being named in the paper is, and that's not really what it means, but that's the interpretation. And I think what we're trying to do is, I mean, that's a very difficult cultural change to shift, and it is shifting, but the way that I think that we need to focus on it is by holding on to our little corners as much as we can and developing pockets of that. If we can develop pockets of trust, people can come and work with us. Even if they only stay for a short time, they go away with that culture and that identity and that feeling of psychological safety as well. So it can kind of be spread in a kind of
It's that power of the ripple, isn't it?
Thank you. Yes, very good. Yeah. So it's not necessarily about process and technique. It's more of a way of being able to actually overtly say to people, that's okay. I will back you up if it's a joint decision, if it's a team decision, if you will be, as we always used to say, judged against a jury of your peers, then that's the right decision. It's the right thing to do. And yes, you might be questioned on it, but it was the right thing to do at that time. And we're not gonna we're not going to go back on that. And that's the important thing. It's as basic as that, really.
So do you think when you're fostering that kind of psychological safety and that kind of inclusion within your team, it's very much about leading by example in terms of how you are as a person?
Absolutely. I mean, I've experienced defensive leadership, if you like, where people seem to be more concerned with stopping complaints and things not looking very good if this happened. And that's not really, obviously that's not clinical decision making. That's not meaningful way of doing things. That's just trying to keep things quiet and make, it just makes me cringe. And it can feel like sometimes it can feel that you're working against the tide when you have defensive leaders, but when you've got a culture of defensive leadership further up the chain and people seem to be more concerned about PR than they are about equitable service user support, that's when it becomes a problem, because we know clinically what things are right, but it's almost like we're expected to be a suicide prevention squad, which isn't therapeutic, which isn't helpful for a lot of people.
Yeah.
Controversial.
But these conversations and are or can certainly be controversial, because we're getting, we're doing that deep dive, aren't we? And I think, to establish or even start change and start that ripple, then there often is a bit of controversy at the beginning of that ripple. But I'm just wondering there, with what you were saying about those defensive leaders, or sometimes there's just perhaps those people in the team that don't feel as though they're those team players, and it it's difficult. I'm just wondering, I guess, what role you feel that individual personalities or different roles play in kind of team success.
I mean, I know from having a slightly outside position now, I can see how different strengths and different personalities can be really frustrated by each other. I mean, we have our doers, we have our people who will just say, yes, I'll go and do that, or that sounds really sensible, brilliant, I'll take that to the team. They all want to be, they all want to be part of that, but you do get people who don't come to meetings even though they're mandatory because they're too busy. You don't get, and it's almost like, I mean, we've got one particular person who is so amazing with tech, but they're it's like the completely opposite of me, except both of us are really not keen on admin. They're absolutely brilliant at tech, and they have these really mad ideas that are really out there, but sounds like they'll really work for like buddy systems and things like that, but when it comes to the day-to-day running of stuff, they can be a bit disorganized, and other people can feel that they're not really focusing on what they should be focusing on. It's about trying to find and celebrate strengths and having the time to do that.
I guess part of it as well, in recognizing those strengths, is knowing your team and knowing the different personalities, and knowing if you've got somebody who likes to do A and somebody who likes to do B, match them up to the right job, because there's lots of different ways and lots of different service users and lots of different roles that we play within those teams.
I think to a certain extent, that's actually really difficult, because you get people who absolutely love working with the service users that I do, and they're really, because my preference is I'm good at putting in boundaries and saying, no, this is what we're doing, this is your support plan, you signed up to it, we are only going to meet once a week, or blah, 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 and any contact you need between the times goes to out of hours or crisis service. This is what we're doing. Other people can't do that. They find that too challenging, and they're better at assertive outreach and looking after people who need more support to engage, if you like. But in the way that we work and that the service user groups, the demographic that we have, if the people who are good at it only took those people, they would be really, really, really weighed down and stressed. And the people who aren't so good at it, well, they would also be really, really stressed, but they would have a smaller amount of stress because they'd have less people. So unfortunately, if we could do that, it would be perfect. It really would be fantastic, because especially since resources have changed and we no longer have like an assertive outreach team for people who really find it difficult to engage, the recovery model doesn't necessarily meet their needs. So, but they need a group of people who can be more chilled out about paperwork, who can be more chilled out about admin, who can just kind of just go and see people and and fine, do stuff with them and just be there and be that person. And the people who used to be really good at that were in a team, but now that's gone, and those people have just been bunged into generic teams. They're expected to do everything, And that we can't do that, and it feels like it's a complete waste of resources. It's really difficult. There should be a way of managing it, but I'm not absolutely sure if there is really.
So how do we manage that conflict?
You see, I'm a bit sneaky because I'm clinical lead. I don't necessarily do that. I'm the operations manager is the one who does the allocations and looks. What I try to do is think about it across in a strategic way with the individual clinician, in that I would say, okay, you've been told everything is urgent. It's all firefighting. Everything comes through with a red flag next to it. And I say, look, if you see that and you feel distressed, you're not happy with this, bring it to me and we'll pick it apart and we'll look at prioritizing. See, it really is urgent and see what we can do. That doesn't mean you've got to go legging it round there and jumping on them, because you won't. Nothing's ever as urgent as it seems when it comes to a community team. Our most urgent assessment that we get is 72 hours. We're not a crisis team, just so it's about being able to give people some space, allow them to ventilate, and then say, okay, how can we look at this in a way that's less stressful? And we can have professionals meetings, we can joint work for a while, we can do there's all sorts of ways that we can manage this without you feeling that you're going to go pop, which is kind of how it is at the moment, to be honest.
So obviously you're working in a really challenging space with very complex service user needs, with lack of resources, fluctuating probably, well-being kind of within the staff group. So how do you build trust within the wider team and like within the multidisciplinary teams you work within, especially when perhaps those roles or those perspectives differ? So I'm wondering, you were saying there that, your most urgent referral would be kind of a 72-hour. Where, when there's perhaps some confusion between your service and the crisis team, how do you build that trust? Is it kind of explaining those expectations and putting those boundaries in place? What are your kind of, I guess, your practical strategies you can offer for our listeners, but also perhaps just some of that inner sort of well-being and looking after yourself within those situations as well?
I think in my experience, people tend to, when things are stressed and difficult, people tend to batten down the hatches and go into silos and protect their boundaries as hard as they possibly can. In community mental health, that's really difficult because we don't really have any defined boundaries. That's something that's being worked on at the moment. But plus in a 24 in a 5-day a week 9 to 5 service, a 72-hour referral KPI is a nonsense anyway, because what happens if that comes in last thing on a Friday? But anywho, it's about using your humanness and talking to people like they're people. And what in my experience, just turning into a pair of goats and butting horns is never going to do anybody any good, and all it does is make you dread the next time you try to have a conversation. So just trying to be as open and as reasonable and as give and take as possible is there are times when clinicians across our team and the crisis team have quite big differences of opinion, but usually there will be a way of working through it, even if it's kind of like a joint work way of managing stuff. It can be managed, and the other thing, again, it's that open communication. It's having really good crisis plans. So again, if the clinician goes into crisis because a service user is having a crisis, they can open the support plan and say, oh yeah, this is what this person does when they're in this place, and this is what's happened before. And you could go to crisis team and you can say to them, this is a plan, this is what's happened, can you help us out? They might say at this stage, no, but have you tried X, Y, and Z? So it's just about that give and take and trying to make the whole thing into a big MDT discussion. It's less easy that's in-house. It's less easy when it comes to GPs, especially in areas where the GP has chosen not to have mental health nurses in their surgery because we are funding that. So we've lost the staff to fill that space, but the GPs aren't having them. So we're expected to do the backfill, which we can't. So there's a big kind of gap in service there that is really kind of can get quite unpleasant between the GPs and our service because we just can't do anything. But they want us to do something, and it's just a bit at the moment. It's a bit of a stalemate, but we are going through this community transformation, community transition within NSFT as well as in the wider world. So that is something that's being looked at, and I'm fortunate enough to be able to be part of those task and finish groups to kind of look at it and say yay or nay, this is a good idea, this isn't a good idea, have you tried X, Y, and Z. The only thing that is a little bit difficult is that our service user group, or a large proportion of our service user group, don't ever want to be discharged, but we have to discharge them. And this is kind of like a for instance moment in that and the defensive kind of higher ups. Case in point is that we spend an awful lot of time putting discharge plans in place and managing, supporting people into transitions to primary care. And we want to be able to say this person should not be referred back until these steps have been taken. This is not yet this is our clinical expertise. This is our clinical rationale. This is what our experiences tells us is the appropriate thing to do. And then the kind of bureaucrats come back and say, no, it's part of the NHS constitution. You've got to allow them direct access. And it's just, what's the point? Why, we're the clinicians. We're the ones who do this stuff. It's our bread and butter. Why are you telling us that we're wrong? And that's the bits where it gets frustrating because it's really difficult to, even though we're kind of advanced leadership, it's really difficult to be able to say, well, this is what we're doing because we don't have that authority.
Yeah.
So there is still very much a rock and a hard place. It is more about managing expectations, if you will.
Yeah, I can definitely hear that frustration. And
Yeah.
I'm just wondering whether there are any particular approaches, because I'm sure that many of our listeners will be nodding along furiously with you, Vicky, and thinking, yeah, we're exactly in the exact same situation, or been there. And I'm just wondering what approaches or maybe what kind of golden nuggets that you have found to be effective in kind of encouraging that shared decision making or shared responsibilities across those professional boundaries, or kind of with service users or within your team. What would be your kind of top tips, I guess?
My top tips would be to involve everybody in support plans. Carers, service users, external services, Mind, the police if necessary, the ambulance service, 111, crisis team, tertiary services like home care that we used to call it, all of those things, and making sure being mindful of people raising concerns about people becoming involved in that support plan, because a lot of support plans have to be really boundaried to support people in feeling contained and maintaining some kind of stability. They need to know exactly what's going on, when, how, and if they have a new person, they try and find a bit of wiggle room, and then that person can think that they're becoming that person's champion, and it all gets really tricky. So we have to be really on the ball about making sure that everyone's involved to maintain the consistency and the boundaries. And to a certain extent, it is like that with staff as well, is that we kind of need to maintain the boundaries and consistency of approach in the team, because if okay, it's that jury of your peers. If you have two or three people who say, no, I wouldn't do that, at what point does that become the norm and that becomes defensive practice? So I guess it's kind of listening, hearing, reframing, and much as I hate to say it, have processes in place so people feel supported. There's frameworks. We have a FACT meeting every day which is focused assertive community treatment, where people who are deemed at higher risk are discussed every day and have much higher level of contact. And I've been really kind of keen to drive forward that everyone who goes on FACT goes on with an S bar, because our FACT is basically run and managed by band fours and band threes. They need to know the situation, background, the assessment and the recommendations. They need to know the purpose of the calls, and they need to know when that person is going to be reviewed. Otherwise, we just go into kind of drift, and people don't know what's going on, and you just end up having those kind of meaningful, how are you today, can you keep yourself safe conversation, and that's not helpful for anyone. It's not helpful for the service user, and it's not helpful for staff. So it's about just making sure that everyone again knows what's going on, knows the plan, and they're able to be consistent with it. And that's where taking it further and further up the chain would be helpful, because then we could have boundary consistent criteria for the team that we could say, this is what we're doing, this is our role, this is what we can't do. So
Yeah,
that would
it's
always
calling
be
out for
my
you
thing.
to write this down, isn't it? And take it forward. But listening to you talking there, obviously again, complex environment, lots of moving pieces. It's a little bit like a game of chess, isn't it, where you're kind of
Yes.
strategically planning how you can get someone across the board safely, if you like. And I'm just
Yeah, and
wondering, within these,
you almost have to outthink them and think,
yeah,
be quite, try and predict, although we're not supposed to do that. We're not allowed to predict outcomes, because it creates certainty in an uncertain environment, or perceived certainty, and we're not supposed to do that. But
yeah, it's
yeah, that is kind of part of it, because to a certain extent you do have to put together the pieces and think about best case and worst case
I guess
scenarios,
it's
and how you can.
assessing that risk, isn't it? And
Yeah,
I'm just wondering then, within the kind of the team or the frameworks, the boundaries, if you like, that you're working within, how you balance that kind of individual accountability in your own professional clinical decision making with that collective responsibility in the team, because so much, like you say, you've got kind of your care plan, but anybody might be picking up the phone or responding to that if it's not your day in work, or out of hours, or etc. So how do you balance that?
that would always be around caseload supervision, the daily MDT meetings, and we do have policies and procedures that we need to follow. That's why it's so important to have that SBAR, because you always get those particular people who'll phone up late on a Friday afternoon, for instance, in crisis, and we will always try at the best of our ability to present them with the same plan that's got them through before, and that's what stands. If there are instances where people will then go and do something in a public place which causes them to be brought in on a section 136 by the police, but as long as those support plans and everything are there in place, then that can be picked up and run with as soon as possible. So usually, I mean, there's always the situation where people will go against a support plan, and you can never say you shouldn't have done that, but you can say, how can we have done this differently?
Yeah. And just for our listeners that aren't familiar, would you just explain what S bar is?
SBAR is a process, an acronym that's used. It used to be used in handovers from when nurses used to, or do still, I presume, make calls to doctors to get them to come and see service users at night on call, and it was you would need to you report the situation, the background of so the situation is what's going on now, background, why they're there, why they're under your service, what's going on in the background. Assessment is why they need to be seen, what's going on in the here and now, why is it a crisis, why are they needing this information. And then the recommendation is this is what this person needs, this is what the plan should be. Obviously, that can change depending on their presentation at the time. If the doctor arrives on the ward and that person is stabilised, then they go away again without doing anything or whatever.
Yeah.
So it's a really clear way of passing on information without the waffle, which clearly someone like me needs.
So finally, Viqui, let's drawing our chat to a close. I'm just wondering, within all these kind of complexities and challenge and the personal toll it takes for us as practitioners working in these spaces, what is it that after all these years keeps you working in this community space with these service users?
Well, the team are fantastic for all their quirks, and you're always there at the end of the day, saying well done, thank you, it's been great, even if it's been a crap one. Supervision, supporting each other, networking. We have some great practice networks. There's the East of England NMP forum webinars that happen every couple of weeks. And service user stories. I am inherently nosy, and this is why I want to stay clinical. I couldn't bear to go off and just be that's one of the reasons why I did this pathway, is to stay clinical, because to progress beyond a band 7 without to progress beyond a band 6 without prescribing, you're a bit screwed, unless you go into management. And I did a bit of management and hated every minute of it. So staying clinical and just hearing people's stories, and that moment when you reframe something and they you can see them make a connection. There's nothing like it. It's just that, oh my God. I explain to people a lot about, I really love the metaphor, the Labrador brain. So we kind of talk about the reptilian brain, the animal brain, and you kind of imagine this kind of creepy lizard, But actually, if you think about it as a Labrador that gets all excited and is there to protect you and sometimes overeats and is a bit chaotic, if you think of that as your animal brain, it's a much more visible and kind understanding of why you are hypervigilant, why you get trauma responses, why you're triggered by things that you don't understand, why you go into that flight or fight response. It's because it's what your Labrador does, and that's what's driving it. And people will say, oh my God, that's exactly it. It's never been explained like that before. And it's just things like that. I guess it's just about bringing people a little bit of peace and helping them feel heard.
Well, Viqui, it sounds like your passion shines through, connecting with your service users and working within your team. Thank you ever so much for taking the time to chat with me this afternoon, and I hope to see you soon.
Yay, you too. Thank you.
Thank you for listening to the Connected podcast. If you enjoyed this episode, please check out the rest of our healthcare leadership series and stay connected.